Okay. Okay. We are going to start today reviewing some concepts that we know are important for you to for your test. So we are going to combine content review and some questions. Uh, Always we start talking about ethical principles. You know that the ethical principles are part of the nursing professions, are written by in the American Nurse Association, and are common to many others nurse professions. Autonomy is probably the most important ethical principle that you need to know. Autonomy is ethics and at the same time is legal. Uh, Remember that when we talk about ethics, are moral principles that are going to guide you the moment of the practice of your profession. I simplify that very simple. When you are alone in a room with a patient, the patient is the client is unable to defend him or herself. What guides you in that moment, okay, are your ethical principles. And autonomy is one of the most important to have in mind. Autonomy is the right that have any patient, absolutely any patient, including psychiatric patients, including violent patients, to be informed and based in this information to take a determination uh, related with healthcare. So a person has the right of accept or refuse treatments, tests, interventions, different, healthcare, okay, related, okay, actions. And as I said before, it includes even people that your logic says that they're not going to understand explanation. But for example, if you need to, because it's necessary, it's beneficial for the patient, you need to restrain a person that is agitated. You are supposed to inform this person, even if the person is confused, why the reason for which you are restraining this person. For example, a psychiatric patient that could be violent, could be even homicidal. These patients, as we will be studying later, can be a place in the hospital, so can be in uh, quotation in prison, but in a hospital, as a prisoner in a hospital against his or her will, because the law allows that. It is, that in Florida, we call this Baker Act, but in Nclex, they call this involuntary commitment. Let me change a moment. Sorry, I apologize. So I can write more easily. Okay. Uh, so when when you see the word involuntary commitment, okay, commitment, commitment, okay, involuntary commitment. This is the term that is used in English. We'll discuss that later. The involuntary commitment is the term that is used in English when a person is a risk for him or herself. I mean, for example, when the person is suicidal or is a risk for others. So, for example, is a homicidal risk. So when a person is in this situation that is a risk for him, for herself, or for others, the person can be taken against his or her okay will and being hospitalized. It's like be a prisoner, like being jailed, but in the hospital. But this person, once is in the hospital, has the right to refuse treatment. So has legally and ethically the right to non-accept, not accepting medication. You need to know that it's the law, even if you don't agree, even if not your logic, because it's the law, but also is an ethical principle. So for this patient in this situation to take medication, you need to negotiate. You need to convince the patient from taking the medication. You cannot force the patient, the client, to take medication. And it is the best way of understanding what is autonomy. That is the absolute and not modifiable right to for self-determination. But this detail is also important to be able to answer questions related with autonomy. Only if the person is informed is when the person can take decisions. You cannot take a decisions if you don't have enough information have to decide if this decision is convenient or not for you. So doctors and nurses have the obligation to be sure that before demanding the patient to take a decision, so yes or not, accept or doesn't or don't accept, give consent or doesn't give consent, to be sure that this person is properly informed. Before asking for consent, you need to be sure that the person is informed. It applies to in a practical way to a question. When you have a question and the person is taking a decision, before the person takes the decision, you need to be sure that the person knows the consequences of accepting or non-accepting a an intervention. And this summarizes the most important aspect of autonomy. But autonomy is complex. Autonomy needs to be discussed later and need to be practiced with questions. For example, to exert, to have autonomy, you you must have you need to be a certain age. You need to be 18 or older, and it has exceptions that we need to study. And the person need to be in his or her mental capacity. So cannot be in coma, cannot be impaired by substances that are mind, altering. And the person need to be informed. So to exert the autonomy, you need to have the appropriate age, you need to be in your mental capacities, and you need to be informed. This is another detail that is important for autonomy. So autonomy, as I said, is the most important of those ethical principles because project into the law, and probably is the most commonly tested topic in nursing. And nurses need to know very well that autonomy cannot be violated, and for that reason need to have a deep knowledge of these different scenarios, the different situations in which autonomy is participating. We'll work a little more later in this autonomy. The autonomy is represented in the point of view of legal in the informed consent. Informed consent is something legal, but informed consent is based in the ethical principle of autonomy. Beneficence and non-maleficence are other two ethical principles that you need to understand. So beneficent and non-maleficent. Beneficent, to be good. Uh, non-maleficence, to not be bad. To be simple, no? To simplify. So maybe you can think, okay, this is two ways of reaching the same end. It is in reality, how I differentiate that? Because for me, it sounds it is the same. If you are good, it's because you are not bad. If you are, if you don't, if you are not bad, it's because you are good. So what is the difference of beneficence and maleficence? Because beneficence is to be good. Non-maleficence is to avoid being bad. Okay. Um, yes, and it's true. Beneficence is the duty to do good as a nurse. So what you need to do to your clients is good. So if for something that is beneficial for the client, um, and non-maleficence is that you cannot be bad for the patient. You cannot do something that could harm or could make the patient worse. Uh, but there is a difference between beneficence and non-maleficence. When you are acting, you are doing something to bring benefits to the client, specifically from the point of view of healthcare, you are doing beneficence. So notice that you are doing what is to do. It's an action. So if to speak, if to move your hands, if to have an action, to do something, to do good. For example, when let me see, when you administer a vaccine to a child, uh, you analyze the pros and cons of the vaccine, and then you conclude, because you're a nurse, you're a scientist, that the vaccine will bring a lot of benefits to the child. And you say, okay, if I administer the vaccine, I'm doing good. It is going to protect the child. It's going to be beneficial. So in that case, you are doing an action that is doing good. But for example, let me see, when you have a patient that is allergic to a component of the vaccine, and a patient has history of a severe allergic reaction to this component, and then when the vaccine is ordered, you check, you review for past history of allergies, and you discover that the patient developed this severe allergic reaction to this component of the vaccine, and then you decide not to give the vaccine and consulting with the doctors to negotiate an alternative so you don't administer the vaccine, then you are, doing something that avoid a harm. No, so if you are not harming the client with the vaccine, that would bring a severe allergic reaction. So it could be an example of non-maleficence when you don't do something that could harm the client. For example, when a doctor tells you, give this poison to this client that is my mother-in-law, that I want to get rid of her, okay? And you say, no, doctor, we don't do that. In nursing, we don't do harm. We cannot do that. It's a crime. We cannot do that. It is a non-maleficent. To make you something funny, to make you understand the difference between doing good and not doing bad, which is a very different situation. So in this simplification of this philosophical discussion, what is beneficence and non-maleficence, you can summarize in examples, okay, what is the duty of doing good for the clients when you do something that is for the benefit of the client, and when you avoid doing something that could harm the client. Justice is easy to understand. Everybody is aware of what is justice. Uh, Justice has to do a lot with uh, uh, be equal, be equality. Okay, mm, is based in the principle that everybody has the same rights and the same obligations under God and under the law, and the justice has to do with that. Nevertheless, you need to understand that this fairness, uh, this equality, um, have limits in the practice of healthcare. You cannot pretend that a patient with, let me see, with a common cold or with, I don't know, scabies is going to be dedicated the same time, the same effort, the same equipment, the same resources in comparison with a patient that has, I don't know, an acute myocardial infarction. So you cannot base injustice to treat the same way a person with scabies versus a patient with a myocardial infarction. So you need to know the limitations of justice in the practice of nursing, and you need to be aware of that. The same way in the order of arrival and the order of care a patient. Okay, if the patient has been waiting a lot to be cared of a rash, and is the time, is the turn of the client, but then suddenly arrive an accident and there are a lot of seriously injured clients, then sadly with this person with the rash waiting for the attention of the rash needs to wait until the people that are at the risk of having more serious complications are cared first. That's why we should not go to an ER with a rash. We need to go to a situation that requires emergency treatment. That's why exists the outpatients, offices and the urgent cares. Veracity. Veracity is easy. Veracity to say the truth, and there is no different type of truth. There is only one truth, and it is something that that is very simple. You cannot lie. You cannot hide the truth. You could postpone giving information because something needs to be done first, like a result of a test, etc. But at the end, the truth need to prevail, and the truth need to be told and not the lies. This is veracity. We'll practice some examples, okay, where veracity applies. Fidelity is fidelity, is the duty to fulfill, to do what we promised, okay? So, for example, if you enter to work in a place and then you sign an agreement that you will protect the confidentiality of your clients because HIPAA demands that when a nurse starts working in a place, and then you forget that you promised, okay, to preserve, to keep the confidentiality of the information of the clients, and then you publish in your social media information about a famous client, etc., just to pretend to boast, okay, then you are violating your promise, and this is a case of an ethical, break of the fidelity. In relation with those examples that I mentioned before, you need to know that you have the obligation to preserve the privacy and the confidentiality of your clients. A person that is your client has a right for privacy. So this information that is not pertinent for the healthcare, like if it's I don't know, could be how many marriages has had, or to whom has been married, or let's see what kind of activities they prefer to do as a distraction. So private information, okay? The patient has the right to keep this information for him or herself, and you need to respect this privacy. So, for example, if you start making non-pertinent questions, it's a violation of the privacy. There are people that like, to talk, and people that like to find information, to ask information. You need to learn that people have the right for privacy. And if this information is not necessary for the attention of the healthcare problems, you don't need to be asking for this information. But there is information that is pertinent for the healthcare. And this information even can be very private. But then, because this information is needed for the care, this information is disclosed by the client. Could be sexual orientation, sexual activities, could be the use of certain substances, could be certain information that is private but is disclosed by the client because it's needed for the health court. And this information must be known for the people, and only for the people that are taking care of this specific health problem. If for any, this is the kind of information that the patient disclosed, that HIPAA, okay, the Health Insurance or Portability and Portability Act covers the confidentiality, the private information that the patient has disclosed to the healthcare providers, okay, and for the nurses, and any violation of this specific type of information that the patient has disclosed because it's needed is what is a violation of the confidentiality. In two words, privacy is more general. Privacy is including everything, even the details. Okay, how many children you have, how are you getting along with your children, how are you getting along with your wife, where do you live, how is your house, how many rooms have your house, okay, do you have a car, how many cars you have in your house. So there is a lot of information that sometimes is not pertinent, okay, to be known. But sometimes people ask those questions. You need to know that asking those questions could be an example of violation of the privacy of the clients. For example, looking at the belongings of the person without the consent of the client, which is something that sometimes has been done, is an example of violation of the privacy. For example, browsing the private pictures or the phone of a client is a violation of the privacy. It is not necessary. It is an example of violation of the privacy. But when the information has been disclosed by the clients because this information is a private information needed for the health care, then in those cases is violation of the confidentiality. And this is legally, okay, included in the HIPAA, and it's very serious. Advocacy is the obligation, the dedication that the nurse or the professional has for the patient. Okay, the important person in this field is the client. It's not the hospital, it's not the owner of the hospital, it's not the government, it's not the physicians. We need to work with all these people and in harmony, but as a team. But the important, the center, the one that need to be the centered address of time is the client. And this dedication, this passion that you put in doing the best for the client is their advocacy. So each time you do something that is beneficial for the client, or you eliminate something that could be harmful for the client, you are demonstrating your advocacy. This is when you understand that not only the education of your mind with science, which is something that we do in the nursing school, but also educating your ethics and your heart to take care of client. And this is what make nursing a science and an art at the same time. All those the stuff that you do for the client is advocacy. So any good and any beneficial is the advocacy. So those are the abstract concepts. Sorry. This is not going to be tested in your Nclex this way. This is going to be applied to question. So let's see some question to see if we understood the concepts. For example, here I have a question. What ethical principle below is accurately paired with a way that ethical principle is applied into nursing practice? So it's a pairing question, is where the pairing is correct. So first say justice. Justice is equally dividing time and resources among a group of clients. So we need to analyze this option. Okay, justice, uh equally dividing time and resources among all the clients. So sounds good, but maybe sounds bad. So let's leave this option there with a question mark to go back and analyze that. Beneficence, doing no harm during nursing care. So here you should rule out this option. Why? Because doing no harm is non-maleficence. Okay, so it's do not harm is non-maleficence. doing good, doing something beneficial for the clients is beneficence. So this can be totally ruled out because it's incorrect. Veracity, fully answering the client's questions without withholding of information. So it sounds correct because veracity is to tell the truth, is to say the truth, and answering the client questions without withholding information, okay, is totally the truth. So it sounds possible also. So let's leave there a quotation mark, a question mark. Fidelity, but you promise. Upholding the American Nurse Association Code of Ethics. This is not a promise that you do. It's a code of ethics that you follow ethically, but it's not a promise that you do, especially a promise that you do to your clients. So it doesn't fit. It is not paired. So we are left with these two options as possible. Justice, equally dividing time, the time of the nurse, and the resources available for the clients among a group of clients, all the clients. Is something wrong here? Is something that it could bring problems instead of benefit? Can you divide equally your time, your dedication, and your resources among all the clients? Is this possible? Yes or not?
No.
No,
No.
no, it is not possible. It is not going to be beneficial to the clients because you cannot dedicate the same time to a patient with a rash versus a person with, I don't know, in septic shock, and the same for the resources. So this is a disqualification of this option. But this option, from the point of view of ethics, is true. So fully answering the client's question without withholding of information has nothing to can be critiqued because it is veracity, is to say the truth. If you withhold information that belongs to the patient, you are not telling the complete truth. So the best option here is the option C, based in this systematic analysis of the options that we have been having. Let's do the same. Let's do the same, with this question. Which of the following is most closely aligned? So paired is again paired with the principle and concept of informed consent. So what is more associated with the informed consent? This paper that you know need to be given to the client going through a procedure, generally invasive procedure, that the patient need to sign. Yeah. So justice, fidelity, autonomy, or non-maleficence. We already mentioned that. The one that is paired and related, the ethical principle that is related with the legal requirement of informed consent is autonomy. So what is informed consent? The patient need to be informed of what is going to be done, why is going to be done, why need to be done, who is going to do it, what are the consequences, good or bad, of doing that. So the needed information need to be delivered. It's interesting that this information, the ideal, the accepted person to give the information is the provider. Provider generally is a physician, is an authorized physician assistant or nurse practitioner, or is a radiologist, can be a dentist, can be an anesthesiologist, is a person that has been trained to do procedures that tend to be invasive and have certain level of risk that requires a written informed consent. And this is what we are talking here, the informed consent, this common document. So this information should be given by the person that is going to do the procedure. So this specific and technique information should not be given by the RN. The RN is not trained in surgical procedures, is not trained in anesthetics procedures, is not trained in endoscopies, in biopsies, in catheterisms. So those procedures are made by people that have been trained to do those procedures. And those people are going to assume the responsibility of informing the client. So remember that the information, remember there's an informed consent, and informed is related with information. So the client must be informed. This information should be given by people with capacity of giving the needed information. So it's the provider, not the registered nurse. Nevertheless, once the information is delivered, okay, the patient, knowing who is going to do that, how it's going to be done, and what is the pros and cons of doing this procedure, will take a decision that is only influenced by the information, the objective information that is given to the client by the provider. And the patient very simply is going to say yes or not. Okay? And this is what means the informed consent. If the person decides yes, then if the person decides yes, is giving the consent to the provider. So it's telling the provider, yes, I want you to do on me what you said should be done. But then to live a an legal, official, written um, proof of this consent and this information, there is a paper that needs to be signed by the client that is called informed consent. This bureaucratic, this administrative step, the paper, the responsibility is of the RN. So maybe the provider is giving the information even days. There is no limit of time. There has not be established a limit of time in which the provider gives the information to the client, and the client tells the provider, yes, I want the procedure. Okay, but it could happen 1 week before, and then the day of the procedure or the day before the procedure when the client is admitted, is the registered nurse the one that brings the paper that the client is going to sign, because it's the way that the system works. And you need to understand that the information was given by the provider, and the consent, the yes, was given by the client to the provider when the provider asked the person, hey, this is the situation. You need to have this surgery. Do you agree with having the surgery? Do you want me to do the surgery in you? Okay. And the patient just says, yes, I want it. Yeah. So it was the information. This was the giving of the consent, but this needs to be in a paper. And this paper is a legal step, is an administrative step, is a bureaucratic step. Is the registered nurse the one that is going to take care of this step? But at the moment of giving this paper to be signed, where the patient is going to say, yes, I'm going to sign that, yes, the nurse need to do two stuff. Okay, need to verify that the patient has been informed. So sometimes the nurse needs to demand the client to repeat, to say, to summarize the information that was given, because the nurse was not present 1 week before into the moment in which the provider gave the information to the clients. And the nurse must verify that the client have enough information, as much as the patient considers needed for him or herself, to take the decision. So the registered nurse is going to ask, okay, what kind of surgery are you going to have? Who is going to do the surgery on you? Do you know, have you been explained, okay, why this surgery must be done on you? So maybe the nurse needs to make an assessment where it is going to, to analyze, to request, okay, a repetition of the information that was given by the provider before. That's the way that the nurse is sure that the patient was properly informed. And very important, the person when asked, do you have any doubt? Do you have a second thought? Do you want more information? Do you have any question to ask for this procedure, for this stuff that is going to be done to do? and the patient needs to be satisfied. The patient doesn't have, okay, more questions to ask, etc. This is a patient that in your assessment is completely informed and is wanting voluntarily, has the desire of having the procedure done. And then you allow the patient to sign. If the person demonstrate that has not been properly informed or has questions, doubts, or second thoughts about the procedure, you cannot allow the person to sign the consent because if the person is not sure that there is one thing that is not completely informed and is a basic concept. So this is the complete concept of autonomy applied to a legal document called informed consent that has this characteristic. You need to understand how it works to be able to answer specific scenario, specific situation questions. Very good. Any question about this? Let's see other example of question. The law prohibits the sale of organs for transplant. It is true. Which ethical principle supports these decisions of the legal system of the courts and the judges, okay, that prohibit, okay, and the legislators that prohibit that an organ, a kidney, a heart, could be sold in exchange for money, okay, in the market? Which ethical principle supports this legal issue that organs should not be sold for money? Is prohibited, okay, selling organs. Non-maleficence, autonomy, justice, fidelity. I want one of you to give me your opinion, how you should answer in a test. Okay, why organs should not be sold in the market? So you have a patient, you have two patients with renal failure.
Is it justice?
One is rich and the other one is poor.
Okay,
It
one
will
is
be
rich
justice.
and the other one is poor. Okay, so this is rich and this is poor. Okay, poor. Okay, and both need a kidney. Okay, and there is only one kidney. Okay, only one kidney available. Okay, if the kidney could be sold for money, the rich person is going to have, okay, advantage in obtaining the kidney. When in this situation, when both are in the same situation, both are human beings, both are needing a kidney. Okay, what could be fair? Okay, could be fair that the rich client, just because has money, has preference for the kidney. Is this fair? No, it's unfair. So in this case, yes, applies justice. Justice. Yes, there is nothing promised there. There is both are informed and have decided that once the kidney transplant, okay, it is not going to harm the client. So obviously, they only apply here the situation is that in this situation, if you are selling the organs, then an injustice will raise in the order of the waiting list of the transplanted people. So that's why, independently of your money or your importance, okay, people are in a waiting list, okay, that is clear as organ appears, okay, based in they are compatible or not, no, if they are rich or not, but the compatibility or the chance of recovering with the transplant, not based in the capacity of buying the organ. So it is an example how justice apply. The nurse is planning a teaching session with a client. The nurse and clients do not speak the same language. It's a very common, no? That there is a client that doesn't speak the language of the nurse. We have a cultural potting melt, and this is a very common situation even here in Miami. The nurse arranges for an interpreter, an official health interpreter, okay, to be present for the teaching session. So the nurse is teaching the client, okay, and to have a proper teaching the nurse is requesting, okay, an interpreter. This is an example of which role or which situation is an example of informed consent, is an example of confidentiality, is an example of quality improvement, or is an example of client advocacy.
Client advocacy.
Absolutely. This is a nurse that puts first the interest and the benefit of the client. This is a nurse that is interested in being sure that the client is learning what must be learned or the problem that is going to be managed. And the nurse understand that if there is a language barrier, that it's impossible for the client to understand. Okay, so is this ethical that I teach in English to a student that doesn't speak English? Is this ethical? It's not ethical. No, so that's why in the nursing school you are required to speak English because is the language that is going to be used, okay, to teach you. Okay, so those are examples of how ethics, okay, apply to different scenarios. Okay, let's continue doing that. A 60-year-old client, okay, 60-year-old client, okay, is younger than me, is diagnosed with lung cancer, but the spouse of this client requests to the nurse to keep him from knowing his diagnosis. When the nurse enters the room, the client asks the nurse, is it true that I can die from what I have? Base can be, is it true that I have cancer? Is it true that I have that problem? Based in which ethical principle the nurse should consider answering this question? In beneficence, justice, veracity, non-maleficence. What is in role here? To benefit the client, to avoid harming the client, to be fair with the client, or to be true to the client.
To be true to the client. Veracity.
Absolutely. So what is in role here is veracity. So independently of the details, okay, that if who should inform the client, etc., if the client has been informed or not, in this case, in these options that are mentioned here, the problem is that if you say no, you cannot die, you are not going to die, you are lying, ¿de acuerdo? Or no, you don't have cancer, you are lying. Okay, so it is simply a situation of true or false, okay, of truth or lies. And here, the concept that applies is veracity. Has this client the right to know his diagnosis independently of what the spouse thinks? Who or who right is going to predominate, to prevail? The right of the client to know his diagnosis or the supposed right of an spouse to hide the information from the client? So obviously the answer is the client right is the what that is going to prevail. And has the client the right to know his diagnosis? The answer is yes, it is a right. And in that case, okay, it is related with autonomy. So has the client the right to be informed? The answer is yes. And what has to do with the right of being informed of the diagnosis of the problems that a person has, is this an adult, is in his or her mental capacity, is autonomy. But autonomy is not mentioned in the options, yes? Because, okay, the question that when are fair cannot give you two possible answers. But here it is also involved the right of this client to be informed. I mean autonomy, a part of the right of the client to be told the truth, which is veracity. Do you get the idea? Okay, so in reality, those questions are many ways of being, worded or being asked, and are good question to put in the test of the morning, the question with one answer, and in the test of the afternoon, the same question with another answer, and making people copy the answer of the morning and committing a mistake. Okay, so take care. Don't memorize answer. Trying to understand the rationales. Why here in this scenario of these four options, the one that apply is veracity. But if veracity were not here, were autonomy, and then what is in play here is the right of the client to be informed. This is autonomy. Patients that have the autonomy right, is everybody has the right to know, the right to be informed. A powerful senator is admitted to the nephrology service because chronic rejection of a previous kidney transplant requiring dialysis again. So the client needs a new transplant. This client is added at the end of the list of clients waiting for a compatible donor of a new transplant. So it is order of arrival. So this client, this is a new client, is going to be at the end of the line, as usually occurs in many other situations. So this client is at the end of the list of clients waiting for a compatible donor of a new transplant. But this is a very important person. Based in which ethical principle, okay, the nurse knows this decision was taken. Which decision? To place in the patient, the client, in waiting list, no matter how powerful it is. What applies here? Beneficence, justice, veracity, non-maleficence.
Justice.
Justice, justice. Exactly. I agree with you. It's a problem of justice because independently of the importance of the person, this person has the same right as the rest of the people to live. Yeah, independently if you are rich or not, if you are famous or not, if you are important or not, the right to the life is equal for everybody. It is even in the Constitution. Continue. Uh, the client complains of pain, 7/10. Okay, pain 7/10 is a severe pain. Okay, we consider mild pain for 1 to 3, 4 to 6, moderate, 7 to 10, severe. Yes, more or less. The client is well known for addiction, so is addicted to pain medication, specifically opioids, which introduce a an element of mistrust in the situation. On purpose, this element of mistrust has been introduced in the question because it's very frequent that people that have chronic pain also have addiction. And the Nclex will explore if you have those concepts clear. In this case, because this mistrust occurs, the doctors, the MD, decides to order normal saline, IV, PRN for pain instead of the morphine that the patient thinks is receiving. So what is this? A placebo. A placebo for what? For pain. The nurse questions, objects, refuse, discuss the doctor's order. Based in which of the following principles the nurse decides to question the order? Veracity, justice, autonomy, fidelity. What do you think?
A.
Everybody agrees? So what is the scenario that a person that is requesting morphine, okay, you go there with normal saline, and inject normal saline, telling the client that this is morphine. What are you doing when you are injecting normal saline and you are telling the client or making the client assume that this is morphine? What you are doing, it is a lie.
You
Mhm.
lying to
And
them.
what has to do lies with this ethical principle? Truth, veracity. Yes. So frequently students say, no, it's the autonomy. The patient has the right of requesting morphine. No, 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 no. Don't confuse autonomy. Okay. People have not the right to request morphine. It's not true. For example, if you have a flu and you go to the MD, if you think that you have the right of demanding antibiotics to the doctors, you are wrong. Some patients think, some clients think that they have the right, because autonomy, to demand the doctor to prescribe, for example, antibiotics for flu. The doctors don't like to prescribe antibiotics for flu because antibiotics won't improve the flu. But many clients, many patients believe that antibiotics are good for the flu, you know? So here, autonomy doesn't apply. A person doesn't have the rights based in autonomy to request morphine. Uh, has the right to for the pain to be treated, but not necessarily with morphine. But what is wrong here is that the nurse is going to the client and is going to tell, I'm giving you morphine, and in reality it's not giving morphine, it's giving normal saline. And this is unacceptable. Why? Because it's a lie. So is placebo a lie? Yes, placebo is a lie if it is used without the knowledge of the client. And placebo has not role, no ethical and even legal role in the treatment of clients. Yes, and especially the use of placebo for pain. And what about if the client is faking the pain? There is no way of knowing. For that reason, in Nclex and in nursing, pain is whatever the client says it is. So if the patient says that is in pain, you accept that the patient is in pain, and you don't discuss that. You don't question that from the patient. You don't put that into doubt that from the patient. Period. So even if the behavior of the client is not compatible with pain, if the client says that is in pain, you must accept that the client is in pain. So if you go to the room of the clients and you ask the client, okay, are you in pain? From 0 to 10, how much? Okay, the patient say, I'm in 9. And the patient is laughing, talking through the phone. Even if this behavior is not compatible with a pain 9 on 10, you must, as a nurse, accept that the patient says is in pain and the patient is in pain. So if the doctor prescribed pain medication for pain, then you are obliged to give the dose and in the interval and the route and all the rights pertinent for the administration of pain. You cannot administer placebo for pain. When placebo is ethical and legal, when there is a research and clients give consent to receive placebo. So in those cases, the clients are going to be said, hey, you could be receiving either the active medication or a placebo for any condition, blood pressure, pain, whatever. You don't know, I don't know. So you are going to receive something very similar in case that you receive placebo as the active medication, or maybe you are receiving the medication and you don't know, I don't know. Do you accept those conditions? And then the patient say, yes, I accept to participate in the research with those conditions. So the patient is accepting that there is a possibility of receiving placebo, and the patient accepts that. In this case, it is ethical and is legal, but the use of placebo in medicine and nursing is unethical and illegal, especially if the placebo is used for pain. It's a lie and it's a violation of the veracity. Simple. Okay, notice that many similar scenarios like this have been actually present in your English, okay? The staff nurse requests vacations. vacations with 3 months of anticipation, and the nurse manager accepts the request. 3 months later, there is a severe shortage of nursing personnel, but the nurse manager authorizes the nurse vacations. Based in which ethical principle the manager decided to allow the nurse to live on vacations? Veracity, justice, autonomy, fidelity. What do you think is playing a role in this scenario of this ethical principle? So what did the nurse manager? The nurse manager gave a promise. Yes, she promised, she accepted the request of the vacation, okay, of the nurse, okay? And what has to do with fulfilling, with, with satisfying the promises? Fidelity, okay? When you promise something, okay, and you carry out this promise, this is fidelity. So the ethical principle that applies for this scenario is fidelity. There is no truth or false related here. Justice is relative in this case, because in some way it's like a little injustice for the hospital, for the needs of the hospital, for the nurse, etc. So it's not problem of justice. Autonomy, no, it doesn't apply here. There is not a right to take decisions. It's simply that the charge nurse promised the vacations with enough anticipation, and when the moment arrived, the vacations were authorized, and then they need to solve the problem of the charges. They need to find, okay, other nurses. So this is fidelity. Fidelity is when you fulfill your promises. Another legal issues that you need to know for your anchors is if you are aware of what is the State Nurse Practice Act. When you see the word act, it happened to me because English, as you know, this is not my first language, and I had problems understanding the meaning of the word act in legal terms, okay? So when you see the word act, is equivalent, it's like a synonym of law. So you can say that a nursing practice law, okay? So nursing practice act, okay, law, okay? When you see the word act, okay, it has to do with a law, a legal term, okay? So the state nurse practice act is the law that regulate the practice of nursing in a state. Don't forget that we're a federation, and we have different states united in a nation, but each state has a level of autonomy, and for that reason, each state has its own state nursing practice act. Are very similar, but they are in some aspects different. There are variation from state to state. That's why in our case is the Florida Nurse Practice Act, the one that is regulating the practice of nursing. And it is included what is needed to be granted the license to practice nursing, which is the stuff that you will apply in your Nclex examination. Okay, in your licensure examination, you need to demonstrate that you have the minimum needed, and it is included in the Nursing Practice Act. There, you are going to have many aspects included, information that you can find in this body of laws. And for example, you are going to find there what is called the scope of practice. Scope of practice is what you can do and what you cannot do as a registered nurse. But also you are going to find there in this Nursing Practice Act what a CNA, okay, an unlicensed personnel, okay, certified nurse assistant can do or cannot do, what an licensed practical nurse can do or cannot do. So these scopes of practice of the different members of the nursing profession, nursing assistants, practical nurses and registered nurses are going to be there to define, okay, the scope of practice, the boundaries of these different members of the nursing profession. And you're going to find anything that had to do with legality, legal, you're going to find that there continuously. So this is the Nursing Practice Act. So each time you have a question, your Nclex, that have to do with legal aspects, you will be referred to the State Nurse Practice Act. So if they ask you which where you find information about your scope of practice, you answer the State Nurse Practice Act. What is the legal source of your license? You say is in the Nurses Practice Act. So it's everything that has to do with legality. Don't confuse this absolutely legal aspect of the nursing practice with the professional aspects of the practice. That is something different. It's not necessarily legal. Even they overlap, no, but is professionalization. In this aspect of the professionalization of nursing is the American Nurse Association, an association, a private association. It's not a government, association. It's not a official, association. It's a private association of nurses. That there is the American Nurse Association, very old, with a very long history, with a very good accredited references, and with a very positive activity, because is a very strong association of nursing that gather all the state nurse associations and all the specialties nurses association, like, I don't know, oncological nurses, IV nurses, pediatric nurses, etc., psychiatric nurses. Every um, nucleus of nursing practice is going to be and associated with the American Nurse Association, and there is a lot of influence from them. They have a lot of lobbyists, deciding laws. They have a lot of resources to do research and to publish research, and they are, influencing a lot, through all those organizations in what is called the standards of care. Standard of care is the minimum adequate, requirement to do a good nurse work, how you perform, patient care. And this is something that comes mainly from research, So don't confuse, look, what is legal, that is a State Nurse Practice Act, with this professionalization of the nursing, that is the American Nurse Association, comes from the American Nurse Association. Another aspect of legality is to understand what is non-intentional negligence and malpractice in nursing. Legally, at the level of a court, there is a difference between negligence and malpractice. But in my personal experience in Nclex and in the practice of nursing, those are equivalent. In the court, lawyers and judges, and Nclex is not a test for lawyers and judges, it's a test for entry-level nursing, but there in the court, malpractice have certain level of bad intention, of maleficence, because the malpracticing person has knowledge that they were doing something wrong that should be done different way. Negligence, there is a less, not necessarily absence, less intention. So it's more non-intentional, yes. But we don't care. I don't care. So I suggest that you don't care. So you treat negligence and malpractice as the same. What is negligence and malpractice? When you do your stuff wrong, when you screw it, when you don't follow those standard of cares, either because you are ignorant, that is not an excuse, or when you are careless, which is something bad and also unacceptable. So both ignorance, recklessness, carelessness are the origin of either negligence or malpractice in their different levels. But either negligence or malpractice can end in the court, okay, with a civil law process, okay, called suit, okay, and you need to know that for a case of negligence and malpractice being present and reach the level of the court and being you involved in that, you need to have three elements that are indispensable. You need to have a duty, you need to have a breach of duty, and damage must occur as a consequence of this breach of duty. What is the duty? The patient is your patient. So the patient is your responsibility. Okay, the victim, the one, the demanding person, okay, is a it is your duty, is your responsibility. That generally is the case. You cannot refuse your duty. You cannot refuse this client. What is a breach of duty? That you don't carry, you don't follow the standard of care, the minimum level of care, adequacy, and safety necessary and accepted by a average nurse with the average common sense. When you perform below those standards of care is when you breach your duty. Yes, when you are not careful with the sterility, when you are not careful with the accident, when you are not careful with the doses, when you don't know how to do no calculation, you don't like mathematics, and you don't make the effort of learning adequate calculation because you don't like it, period. This is a breach of duty that can bring you to the court. Yes. And of course, as a consequence of this breach of duty, a damage must occur to the client. Damage is necessary to happen to take you to the court because the client is going to demand compensation from you, and there's going to be the demanding. Okay. How it is tested in Nclex? Many ways, or they can directly test you if you know that you need those three elements to have a case. But more frequent than this question is they are going to give you specific situations in which you demonstrate that you are violating the standard of care, because there are a series of knowledge that to have the license, a series of knowledges that you need to learn in the nursing school before being granted the license. And for examples, okay, three examples that brought to my mind that have been in English. Okay, a nurse is giving atropine to a patient diagnosed with glaucoma. It is an example. Nurses must be taught and must learn in the school the anticholinergic medication dilate the pupils, and the dilation of the pupils can acutely and severely increment the intraocular pressure, producing an acute close angle glaucoma that can end in hours with the loss of the vision of the client. So giving atropine in glaucoma is a breach of duty, and it is a violation of the standard of care, is something that any average nurse graduated from a nursing school is demanded to know. And giving atropine in glaucoma is a breach of duty that ends.
I speak of scope of nursing, American Nurse Association.
Okay. I don't know if it is a question of a statement, but it is sounds that yes. And damage can occur. Another example of how can be which of the following situations could be considered a negligence or malpractice: robbing the abdomen of a child with Williams tumor, is another example that you need to know is if you graduated from a nursing school that Wilms tumor, the most common solid abdominal tumors in pediatrics, cannot be palpated, cannot be touched, cannot be rubbed, because could be a cause of rupture of the tumor, dissemination of the cancer, and bleeding. Or initiating oxytocin in a client whose baby is having late deceleration. You need to know that the first that need to be done late deceleration is the interruption of the oxytocin, not continuing or initiating the administration of oxytocin. So those are being examples of situations that appears in Nclex where the malpractice is in a scenario, a possible scenario where there is a duty, a breach of duty, and a damage, a consequence for the client. The other legal aspect that has been certain frequent in Nclex, and you need to know, is the Good Samaritan law. You need to understand what is Good Samaritan law. It's a law that promotes the people that are useful, people are able, have been trained to help, properly help in case of emergency that occurs outside of the hospital. The Good Samaritan law applies outside the hospital in scenarios of emergency, generally catastrophic scenarios. And because it's very useful, okay, to promote nurses, physicians, medical technicians, etc., that have some training in helping in those situations to stop and help. But to decrease the fear of being involved in legal issues of non-intentional negligence in those situations, then there is a law, the Good Samaritan law. The Good Samaritan is the person that stops to help, in which the person is protected of being sued, of being demanded for non-intentional negligence, some things that could happen. Nevertheless, what is tested in Nclex is in which situation Good Samaritan law does not apply. So first, it does not apply when it is a routine scenario, like in the hospital, a clinic, you know, when the nurse is doing something that is their expected work. It refers, is apply only in emergencies, in catastrophic emergencies like motor vehicle accidents, etc., etc. The other aspect that is super frequently tested is that during this care, emergency care that you administer to a client, you don't commit a gross negligence. For example, what could be a gross negligence in the care delivered in an emergency? That you don't take care of the immobilization of the neck, the stabilization of the neck when you remove the client from the harmful situation, from the harm. We know that the first that we do when there is a polytraumatized client is to stabilize the neck to prevent more injury in the cervical spinal cord, which is catastrophic. And when we mobilize the clients, we can take care of the stability of the neck and the head while doing the movement. If it is demonstrated that you don't take care of this detail, it is a gross negligence. For example, when there is a bleeding, we know that pressure could help stop the bleeding or decrease the bleeding. But this pressure should be done in a way that minimum contamination occurs in the wound that we are pressing. So if you use, for example, a highly contaminated cloth, okay, that has been, you know, full of dirt, to do this, okay, it is, for example, a gross negligence, etc., etc., etc. So this is one of the stuff that they ask about that. The other is no abandonment. When you stop, you need to stay. You need to stay until the adequate rescue, the adequate care arrive. You know that in our system, okay, there are emergency ambulances and rescued, okay, that will arrive to the site, but will take a certain time because there is traffic, there are certain distance. And if you stop, and you decide to stop, you need to wait until this help, replaces you. And if you live before this, it is abandonment, and abandonment is abandonment is an example of exception that disqualify the protection of the Good Samaritan law. And the other one is compensation. Compensation is that you don't receive any benefit, economic, material benefit from the action that you develop, okay? So if you accept a gift, for example, not only money, gifts are included, this disqualify you from being protected by the Good Samaritan law. Okay. The most frequent question is that if you are able to identify what is a gross negligence, but any of these can be present. The scope of nursing practice is legally defined by the State Nursing Practice Acts, professional nursing organization like the American Nurse Association, hospital policy and procedure manuals, physicians in the employing institution. So I hope that all of you are selecting the option A, because the scope of nursing practice, okay, is a legal issue that is delimited by the law of the practice of nursing in the State Nursing Practice Act. The code of ethics is moral. Ethics is professional. It's a code of moral guidance in a profession. It's not legal. Has legal implication, but it's not legal. The code of ethics for nurses is composed and published by the State Nursing Practice Act, the American Nurse Association, the Medical American Association, the National Institute of Health and Nursing Division. No, you know that this professionalization aspect is related with the American Nurse Association. So those are two examples of situations in which you need to know the difference between the State Nursing Practice Act, that is a body of laws written by the legislature of the state, and the Congress of the state, and is enforced, okay, is enforced by the state nursing board of nursing. And the code of ethics and anything that has to do with standard of practice, research, knowledge, etc., professionalization, is more related with this association of nursing that is the most important in our country, that is the American Nurse Association. A 65-year-old female arrived in the ER with chest pain, be a myocardial infarction, angina, etc. The nurse accidentally administered 10 milligrams of morphine instead of the 4 milligrams prescribed by the healthcare provider, probably a calculation mistake. Later, after this more than double dose of morphine given, the client respiratory rate is 11, a little low, but not critically low. Oxygen saturation 98% is okay. There is no hypoxia. And the nurses state that her pain has subsided. What is the legal status of this nurse that committed this mistake? The nurse is guilty of negligence and will be sued. The client will not be able to prove malpractice in court. The nurse is protected by the Good Samaritan Act. The healthcare provider should have given the morphine instead of the nurse. What do you think?
B.
Then, okay, if you say A,
B.
if you say A, the nurse is guilty of negligence. You need to have all the elements of a malpractice or a negligence. You need to have duty. Is there a duty? Yes. You need to have the breach of duty. Breach of duty. There is a breach of the duty? Yes. Okay. It gave an overdose? Yes. And you need to have harm. You need to have a damage. Is there a harm? Is there a damage in the patient?
No.
No, because the patient is okay. So can the patient, okay, sue the hospital, the nurse, the physician, because a medical error was committed? No. Why? Because it's missing one of the elements of malpractice. So the client would not be able to prove malpractice in court because there is not damage, there is no harm. So it is an example how legally is applied. Is this a medical error? This is something that requires attention? Yes. A medical error has occurred. Yeah. And what this nurse should do if commits a medical error? I mean, if give inadequate dose, if give the wrong medication, if give the right medication to the wrong client, etc., etc. Well, the first that the nurse need to do is to assess the client, the victim of the mistake of the medical error, to determine the consequences of this error. So, for example, if by mistake gave a blood pressure medication to the wrong client that doesn't suffer of high blood pressure, then the nurse, first that the nurse needs to do is to assess the blood pressure of the client to determine if it is low and initiate safety precautions, because what is the most probable consequence of having low blood pressure? You can faint, you can have a syncope. So you are going to request the client to stay in bed, okay, to avoid getting out of bed, because then the orthostatic hypotension can make the patient fall and have harm. So this is the first in the case that the nurse should do. Then should call the doctor to inform that she or he committed a mistake. Doctor will order interventions to minimize and to avoid the consequences of the mistake. And you are going to document that you call and the order that you receive, and you are going to carry out those orders. You need to document in the patient record. You need to document what happened. Okay, you need to document that you gave in a factual way. For example, in this case, you need to document 7:30 p.m. Okay, in the patient record, morphine, 10 milligrams IV stat administered. Patient evaluated, blood pressure that, respiration 11, O2 saturation 98. MD informed of the dose of morphine administered. So notice how I documented that. I documented the facts. I didn't document my interpretation. I didn't write. By mistake, I gave 10 milligrams of morphine instead of the 4 milligrams ordered by the physician. Why I don't write that? Because it is not necessary. The doctor's order in the same record says morphine 4 milligrams. And what I am documenting, morphine 10 milligrams administered. So there is the fact. Anybody that can read, anybody that can, do basic calculation knows that I gave a different dose without need of saying by mistake, because I was very busy, I was very confused, I was very, 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 nervous. Okay, you don't write this kind of information, subjective information that is not needed and is going to complicate even more the case. You are obliged to document facts. Like, for example, this 7:30 p.m. morphine 10 milligrams giving IV stat. And then you need to document whatever you did for the client. So I kept the clients on bed. I, observe, continue monitoring the respiration of the clients and the O2 saturation. I reported to the doctor. Doctor didn't, order anything extra, and patient, because the patient tolerated well the medication. Patient state that is not in pain. You need to document that. Okay. And then after you document that, you close your medical records, and then you take a form that is a part of the medical record, that is the incident report. Sometimes Nclex call that variance report. Instead of incident, they call variance, okay? Variance report, okay, which is the same. And then there are going to be questions that will be asked to you about why you think that this mistake was committed, et cetera, et cetera, et cetera, et cetera, et cetera. Okay, so this document is the one that is not mentioned in the record. This is the document that any copy can be taken, and this is the document that is going to be taken to a special department of the facility called risk management. Risk management will analyze why this incident, this variance occurred, and will take the intervention necessary to avoid that from happening again. That's it. So it's important that you have those concepts clear, because it's part of the management that the Nclex will be testing on you. It's frequent that you have in your Nclex, if you know the components of this instrument of communication among the members of the multidisciplinary team. Remember that we are working with physicians, of different type of physicians, other nurses, licensed practical nurses, nursing assistants. We are going to be working with dietitians. We are going to be working with physical therapists, occupational therapists, etc., etc., etc. And when we communicate with others, we need to communicate in a systematic way, an organized way, in which the pertinent and necessary information is included in an organized fashion. And this is the purpose of this SBAR, okay? This organization of the communication, in which the S stands for the situation, what is happening. What is happening that requires communicating with another person, okay? So obviously, if there is all routine, nothing different is happening, everything is expected, there is no need of communication, probably. So when there is a need of communication, when something is happening, generally a variation, generally a change. For example, a person that presents suddenly fever, a person that presents, pain, a person that has a problem with a diet, a person that has a problem. And then is what raises the need of communicating. So this problem, this new situation, the situation that moves you to communicate, is the situation, is what is happening, is the new stuff, is the change of condition, is the situation. Everything should be useful, factual, and brief. Okay, you need to avoid too much verbal exposition. It's just very succinct. And then come the B of the background. Background is the past, the pertinent past history of the client. So you're not going to give all the life of the client, only those aspects of the past life of the client that could be important. So you need to discriminate which one is the important to the situation. Like, for example, you have a patient that has, shortness of breath of new onset, and the patient has surgery yesterday, or the patient has a fracture in the legs today. Okay, so those are pertinent background that are pertinent to the fact that the patient is having a respiratory distress. And then comes the objective component, the assessment. Generally are objective findings in the physical assessment that again are pertinent to the situation. So if it is a respiratory distress, what is pertinent there is the lung auscultation and the O2 saturation, for example. Yes. So what is pertinent and what is adequate. And then come the arc, which is the what you think that should be done, what you suggest to be done, what you analyze is the situation and you suggest to be done. That is summarized into recommendations. So this is something that you need to know. Is frequently tested in Nclex with questions like this. The nurse calls the MD because a client is dehydrated. The nurse tells the doctor that the patient has type 2 diabetes. Which part of the SBAR is this last statement? What is the last statement? The patient has type 2 diabetes. So what is the answer?
B.
Of course, without doubt, it's B, is the background. So the patient is diabetic for years. The situation is that the patient is dehydrated. But the background, which is the situation, is that the patient is diabetic. Is pertinent, is important to have diabetes if the person is dehydrated? Yes, because even the cause of the dehydration could be the own diabetes. But for example, any infection, diarrhea, flu, etc., can decompensate the diabetes and even be two problems: the diarrhea plus the diabetes decompensated, both dehydrate the client. So it is pertinent. It is definitively pertinent. So yes, there is nothing mentioned there about assessment or recommendation. There is very brief, okay, situation that is the patient is dehydrated, which is the situation, and has a background, a past history of diabetes. Let's see the other. The nurse tells the doctor a post-operatory client has had fever when checked him for feeling warm. So the nurse found warm the client and that. What part of the SBAR model is this statement? The patient is warm and has fever. What part of this model is this? Is the situation, the background, the assessment, or the recommendation?
Situation.
Why are you calling the doctor? Because there is a
Awesome.
change in the condition of the client. What is the change of the condition of the client that had surgery yesterday? Has fever, is warm to the touch. Yes. So apparently the patient is complicating with an infection, possibly an urinary or pulmonary infection, without the one that appears so early after a surgery. So this is the situation, guys. This is why you are calling the doctor, because now you have a patient that is not expected to have fever because surgery should not produce fever, and now is presenting fever. One of the confusion that you have is, but this is assessment. Okay, if I say the patient has temperature 103 Fahrenheit, this an objective finding when I measure the temperature could be assessment. But in this case, you call the doctor to tell the patient is warm, the patient has fever. Yeah. And you can say that somebody has fever even without measurement of the temperature. Okay. If you are a parent, you know that. If you are a mama or a papa, you know that you can tell if your child has fever even before checking the temperature. Of course, it's important to check the temperature to quantify and objectivize the finding. But calling the doctor because the patient has fever is the situation, is the reason for communicating with the client. So you need to be able to discriminate what predominates there. What predominates there is the fact that the patient has fever as a change of condition, which is pertinent. It's important for a patient that has a background of recent surgery, because you know that infectious complications of the surgeries occur with certain frequency. Uh, Going back to what I already mentioned, okay, of the way.
Professor?
Yes.
Sorry, is the last one is the answer the situation?
In these questions, in that the
Yeah.
patient have fever, the
Yeah.
situation is the answer, yes.
Okay, situation. Okay, thank you.
Situation, yes. Situation, because it's the change that that move you to call the doctor. Very good. How you document is tested. How is tested in a similar question like this? They give you a scenario on ABCD documentation, 4 documentations, and you need to decide which of these 4 documentations is the best, is the correct. So you can summarize for your mental organization that a documentation in nursing must have 2 virtues, two characteristics. Should be factual, facts, not interpretations. Nobody cares what you think. The facts are the important, the one they need to be documented. Each one, depending on their purpose of a specialty, will take their own conclusions. They are not interested in your conclusions, in your opinions. They are interested in the facts, and they will reach their own conclusions. You need to accept that. In any moment, okay, when there is a a situation like this, it's a technical, is a clinical situation, is a legal situation, all those situations, the important are the facts, not your opinions. Yeah, because the opinions are very subjective and variable and are not the most important. Okay, so don't feel offended, but what is interesting for the others is the facts, not your opinions. Okay, and factual is a characteristic of a good documentation without the contamination of your opinions. And the other, to be detailed. Okay, detailed is that you give the most precise and the most complete information possible. Factual and details are the virtues of a good documentation. So how can be tested in your Nclex question like this? A child with a fractured femur is brought to the ER by the parent. The parents state that the child fell off a sofa. On examination, the nurse finds several blister areas in the child's buttocks. These could make you suspect that those could be burns, okay, cigarette burns, okay, areas. Good. Which is the appropriate form the nurse should document these findings. And then you have 4 documentations. One says 6 areas of 1 centimeter diameter redness, blister areas noted in buttocks. The other say multiple small burns marks noted on the buttocks due to child abuse. The other say blister and reddened skin noted on buttocks due to unknown causes. And the last says several areas that appear to be cigarette burns noted on buttocks. Of these 4, which one you think fulfill the characteristic that should have a good documentation, factual and detailed?
A, B,
C. O A.
Okay, so I heard many letters. Some say A, but also I heard C, and I think that D.
B.
Okay, so let's see factual, facts. Okay, what is seeing the nurse when using her 2 eyes? Okay, and is seeing something in the buttocks. So, and then in option A, the nurse is documenting what she or he is seeing. 6 areas of 1 centimeter diameter, red and with blisters, localized in the buttocks. So it is a fact. Yes, it is a fact. Is there interpretation there? No, there is no interpretation. The nurse is not giving interpretation. The nurse is only describing what the nurse is seeing. Is the nurse suggesting that these are burns, or suggesting that those are, I don't know, shots or dirt, of rubbing trauma or infection? No, it's not suggesting anything. It's just saying what she or he, the nurse, is seeing with the 2 eyes. Yeah, 6 areas of 1 centimeter diameter, recnet, blister, areas not in the buttocks. So there is interpretation there? No, no interpretation. It's not giving her or his interpretation. The other options say multiple small burn marks noted on buttocks due to child abuse. Is there an interpretation there? There is an opinion there. Yes, there is an opinion there. You are assuming that it is child abuse. And you are writing in the documentation that this child has been abused. Okay? And it implies that somebody should be blamed of child abuse. Okay? And apparently the child lives with their parents. Okay? So you are assuming the responsibility of giving your opinion and writing your opinion that this is a case of child abuse. So you have enough proof that this is child abuse, that it has been produced with cigarettes, and this is a way of child abuse. You have enough proof to give this opinion, and you are writing that. By the way, you need to be very careful doing that if you write B, because the parents could interpret that as you are blaming them, and they can take you to court because it's a defamation of their, role of parents, and it is something that uh, is need to be defended, need to be discussed in court, okay, and it brings you a lot of problems. So there is an opinion there. This is not fact. This is an opinion. Blister and recnet skin noted on buttocks due to unknown causes. It is also an opinion. Your opinion is written there that you don't know the cause of the lesions. So is this also an opinion? When you compared A with C, there is an opinion. Your opinion, there is unknown causes. This is your opinion. No, we cannot say what is the cause of that. It's an unknown cause. And the last one, okay, is giving also an opinion. You are giving the opinion that these marks were produced by a cigarette, not a tobacco, not a hot metal or rod, but by cigarettes. Like if you were watching, witnessing the person with the cigarettes burning the buttocks, which is also your opinion. So notice that B, C, and D, you are writing opinion, and you love to give your opinion. When there is a group of people talking, you speak, even you raise your voice to give your opinion. Okay, in documentation, writing documentation, in this, your opinion is not convenient, is not pertinent. The facts, what happened, facts, you know what I mean? Facts, yes, is the one that need to be documented, not your opinion. The people that need to take decisions, the people that are expert, the people that need to know what happened, need the facts, not your opinion. Understand? So it is one element that I want you to learn to analyze in a documentation. And the other is the detailed. Okay, what is better, 6 areas or several areas? Several areas can be 3, yes, can be 3. Can be 7, yes, can be 7. Can be 10, can be 10. All those are several, yes? 6 is 6. It's not 7, it's not 5, it's 6. So what is more detailed, 6 areas or several areas? The same happened to multiple. Multiple is the same as several. What is more precise, more detailed, 6 or multiple? So those are, stuff that you need to be able to identify. Yeah. Even this doesn't mention how many. Okay. They don't mention how many lesions are. So notice that A is also given the size of each one of the marks, are describing that is red with blisters. They don't say that burns, but it's very suggestive of burns. Okay, what is the role of the registered nurse when there is a case of a child or an elder, an old person that could be abused? Well, the responsibility is to report the situation to the chain of command, to the authority, to the protocol that is followed in this specific facility to report those cases of abuse. This is the responsibility of the registered nurse. Is responsibility of the registered nurse to investigate and find and document the proof that this is a case of abuse? The answer is no. This is not the work of the registered nurse. The registered nurse obligation is to report, to tell, to say, to to raise the alarm when there is any suspected child or elder abuse. And there are different ways of to whom to report that. This is not going to be tested because to whom is going to be reported is variable depending on the facility, the state, and the situation, even the city. Is that you are obliged to report, okay? But there are experts, people that are trained to find legally the proof of this abuse once it is reported and what need to be done to protect the child. Okay, so the role of the nurse in a case of abuse is first take care of the lesion. So if there is something bleeding, something that requires cure, take care of that. This is nursing. Okay? And then prevent the child from being abused even more. Yeah, because it can happen. The abuse can happen. They continue in the hospital, and then to report your suspected abuse. Sometimes when you are not very sure that you need to report, maybe it's convenient, okay, to do a little more assessment, like ask the parents to leave the room and ask the child how it happens, how those lesions happens in your butt, okay? Maybe the child, without the presence of the parents, could tell you more information that you can pass as another element to report abuse. It is okay, but the obligation of finding the proof of this abuse are not in the scope of the registered nurse. It's in the scope of other people, other experts. Your obligation is to report that you suspect abuse. The other need to determine if it is feasible or not, it is possible or not. And the way of documenting is factual and detailed. You should not be documented the accusing anybody of abuse because not always can be proof abuse, and then you can be in a legal problem if you are accusing something that you don't have proof. Okay, so now this is an example of question to practice. How is tested in Nclex, okay, an adequate documentation? It's a common question, okay, that you have 4 documentations and you need to choose the best documentation. And don't forget these 2 properties, factual and detailed, and understand what means factual. This is something that we have a lot of problem to understand because we love to give our opinion, even to impose our opinions. Okay, it is not needed in the documentation in nursing, our opinions. Is needed when they are privately asked you, or is needed, for example, when writing the incident report. But in the records, okay, documentation, you need to be very careful to be factual, to avoid giving opinion. It is going to bring you into problems. Don't forget that. Very well. Another details that are frequently tested in Nclex about documentation are, for example, when you commit a mistake, any kind of mistake, you documented in the wrong record, or you documented something that is not what you wanted, then you need to cross out the documentation with a fine line, with a very fine line, okay? This fine line need to allow any person to read what has been crossed out. So this fine line should allow the other people to read what is written. And don't write error. You simply a part of the line, you put your initials. You put your initials, and that's it. Don't write error. That's it. This is the way of of correcting errors when you document. You cannot erase after it is documented. Okay, it happens also in electronic, okay, records, okay, word, okay, once it's written and you save, you cannot go back and erase what you wrote. You need to cross out. And never in paper documentation, never use whiteout. Never cover with a whiteout the documentation. It's important also and tested that when the nurses document, okay, without leaving blank space. So empty line is filled, next empty line is filled, and any empty space is left. If for any reason somebody leave forgetting documenting something, you don't leave a blank space for this person to document later. No, you document in the next empty line, and this person that forgot to document needs to come after you later and write late entry. This is legal and is perfectly accepted. Okay, so don't leave blank space for other people to document missing documentation. Please, when you are writing figures, numbers, don't forget that zeros are important. Even the zero has no value, zeros are important. There is one zero, okay, that is called the heading zero, that must be always present. If you are writing, for example, 0.7, never write 0.7, as some people, okay, but the bad habit of doing. Because if the point is faint and the person has bad sight and reading 7, no 0.7. But if you write 0.7, there is no way I can commit a mistake. Uh, which of the following documentation need to be corrected or follow or whatever, and then somebody wrote 0.3. Okay, this is incorrect. And the other zero that in that case should not be present. So the heading zero always present. The other zero that should not be written, some people have the bad habit of writing, for example, 5.0. If you don't see the points, I'm reading 50. In reality, it is 5. I always remember that even some books write potassium level 3.5 to 5.0. It is wrong. It is incorrect. Yes. Okay. So never, okay, include the trailing zero because it's going to bring confusion. It is very common, okay, very common stuff. In case of units, like in insulin and other hormones, don't abbreviate units that can be confused. Give insulin, okay, 5 units, and maybe, okay, the person interpret the unit as a 0 and is giving 50 units instead of 5 units. And avoid acronyms and abbreviations. Even in the hospital jargon, especially here in English, people love to use acronyms, and is a way of demonstrating that you are not a rookie. You are part of the team. You are part of the of the of the group. No, when you use jargon and abbreviation in Nclex, don't do that. Okay, it's not adequate. It brings confusion and problems. Okay, so it is good for documentations in English question. So look at this, a young adult female arrived to the ER with a black eye and is bleeding from the left side of her head. She reports that her boyfriend has been abusing her physically. The nurse performs a history and physical examination. How should the nurse document those findings? So read the 4 documentation and tell me which one is factual and detailed.
D.
I agree with you.
D.
I agree with you, you know, because you are giving here an opinion that has not been said for her. Okay. She just said, okay, my boyfriend had been abusing me physically, but never said that the boyfriend beat her up, because maybe those injuries are not necessarily produced by the boyfriend. Maybe she fell from the stairs. It is not mentioned there. Okay. And then the description is very incomplete. So don't good. Client report her boyfriend hit her. In which moment she said in this scenario that the boyfriend hit her? It's the same that I said here. So it is not true. It's not factual. Yes. And bruises and laceration present on face is there's not enough information here to know, to visualize what is happening. It's not. It's not good. Client present with right black eye. It is not very medical, no, the right black eye. Ecchymosis is much better. And a cut. Cut is not neither a medical term, that we use. Laceration or injury or skin breakdown, wound is more acceptable. In the left side of her head, but the left side of the head is huge. Can be the temporal area, parietal area, the frontal area, the periorbital area, could be the cheek, with the mandible, could be many areas, no? So it's not. Reports abusive boyfriend. Responsible for the injury. She never said here that the boyfriend was responsible for those injuries. It's only saying that her boyfriend is abusive physically. Needs referral to a safe place to stay. What is this? Is your opinion. Very interesting opinion, but remember, the good documentation is without opinion. Okay, so obviously the last one is the most complete, is going to be factual. Young adult female present with periorbital ecchymosis on the right side. Periorbital is around the eye, the right eye. 3 centimeter laceration, the left parietal area, very well precise. 1 centimeter deep with tissue bridging. And she says, okay, her boyfriend is abusive. She said that. So it is much, much better. You can state and trying to use quotation marks, okay, what patient says. A client, let me see those questions, okay, to practice a little. A client is involuntarily committed. You remember that Baker Act in Nclex is not mentioned because Baker Act isn't law only in Florida, and Nclex is a federal test. We use the term involuntary commitment. Okay, a client is involuntarily committed to a psychiatric facility. During an assessment, the client reveals to the nurse a plan to harm a specific family member. His family member. Assume that is a his. So it is a question to bring you a legal detail, because we're going to about the legal aspects of the nursing that you need to know. The obligation that you have, and everybody has obligation, okay, to inform, to warn, okay, to warn, to report, to warn, okay, a threat, a homicidal threat, okay. Which of the following action is a priority? Ensure the provider and the family member is notified of the threat. both the doctor and the family member that the person is threatening. Encourage the client to discuss the plan to harm the family member with the healthcare provider. It is not bad, it is good, but something is missing here. The family member has not been warned, has not been, make aware of the threat. And then if something happens to the family member, then you are liable because you are supposed to find a way of informing to make the family member being informed of the harm. Okay, this is a kind of information that is not covered by confidentiality. Not all information is covered by confidentiality. If somebody is threatening to commit a crime, you cannot promise confidentiality to this client. You need to warn the person that is telling that to you that you are obliged to report this. There is no confidentiality for crime, for infectious diseases of mandatory report, for abuse, for firearms wounds. So there are some exceptions that you also need to know for confidentiality. So even if the person tells that you as a private information, you need to tell the client that sorry, but confidentiality is not going to refrain you from communicating, okay, that to the authority, to the physician, and to the person that has been threatened. Incorporate the client's plan to harm a family member into the nursing plan of care. This is not enough because it's not informing the family. No action is necessary. Yes, action is necessary. Action is necessary. And this information is not protected by the confidentiality. So there is a obligation, a duty to report any threat to a person because it is called the Tarasov law. Okay, it is based in a precedent of the common law in which a girl, the boyfriend, okay, consulted a psychologist in the university because he was feeling the need of killing his girlfriend because she dumped him. And the psychologist, reported to the police department, reported to the authorities of the school, but forgot or failed to report to the girl. And the next day, the guy went and killed the girl. And the last name was Tarasov. And this is the Tarasov law, okay? And it's something that we nurses need to know and has been okay, tested. So summarizing, if somebody has been the object of a criminal threat, a part of informing the authority, you need to assure that this person has been informed that this threat has been issued against him or her. Intentional tort, when you do something illegal, on purpose. It includes the assault, battery, false imprisonment, and defamation. Also is tested, also need to be known by you. Okay, assault. Okay, you can learn that assault generally is a threat. So it is generally verbal. It doesn't reach the level of the physical contact. So assault is when you threat of doing something that could be harmful or offensive. Yes, with or without contact. So, for example, when a nurse, okay, tells a client that is refusing to have a medication, suppose that is a client with, moderate dementia in a nursing home. So then you hear the nurse telling the clients, if you don't swallow this pill, I'm going to tell the doctor to order a tube that I'm going to introduce through your nose down into your stomach to pass this pill. So what is this? You are threatening the client of doing something that would be painful or uncomfortable and to produce fear in the client. Okay, this is a case of assault. For example, if the client refuses to take a shower and you are hurt telling the client, if you don't take the shower because you are very dirty, then I want you allowed to go to the dining room to have your lunch or whatever. It is another example of assault. Okay, so if you don't take the medication, I'm going to give the medication with a shot. Okay, is another example of assault. So you are just verbally threatening, okay, the person. So assault is a threat, and generally threats are verbal, okay, without actual action or actual contact. Battery is different. Battery, there is contact, there is touching, yeah, and this touching of the client is without the client's consent. So when you touch a person, okay, for example, when you beat a person, when you hit a person, when you grab a person, yes, when you push a person, when you restrain a person without the person's consent, it is considered battery. So there is a physical touching. Okay, this is battery. When without authorization, you touch the client. The authorization can come from the physician in the case of restraints, or can come from the own client. That's why, for example, when you are going to check the blood pressure, you need to obtain the implicit consent from the client. So if you are going to check the blood pressure of a client, before wrapping the arm with the cuff, you are going to tell the patient, I'm going to take your blood pressure. And you see that the client extend the arm. What is this? It is an implicit consent. Doesn't need to be signed, but it's an implicit consent. But then if the patient say, no, I don't want you to take my blood pressure, okay? And then you force the client to take the blood pressure, you wrap, okay, against the patient consent, the blood pressure cuff, this is a case of battery. A common question about battery is when a surgeon does surgery in a client whose nurse forgot to make the client sign the paper of the informed consent. You remember all the story that I explained, no? So suppose that the nurse forgot and everybody forgot to have signed before the surgery the consent. In those cases, but is accused the surgeon of battery because did surgery without an evidence of the consent of the client. Another example of battery that I seen in Nclex, when a patient is known, well known, have an identification event of being DNR, do not resuscitate, and for reasons that are not pertinent, the nurse or any person does chest compression, does CPR in the client. This is also considered a case of battery because you are touching the client without the client's consent. False imprisonment has two frequent situations. One situation is when a person is in a facility, is in hospital, is in nursing home, is whatever, and you don't allow the person to leave this facility if the person wants to leave. So even a person should be hospitalized, the person has the right of leaving the facility, even against the medical advice. It's important to remember that when a person is leaving the facility against medical advice, you need to make the clients aware of the consequences for him or for her of leaving the facility against medical advice. But the client has the right of doing that. The only client that has not the right of leaving the facility is the involuntary commitment. Okay, is the involuntary commitment that has not the right of leaving the facility until this commitment has been left. And the other case of false imprisonment is when you apply physical restraints, either seclusion in psychiatrics, that is to place a client in a safe room under lock, or physical restraint with, wrist on legs restraints, so tying the client with ropes, with restraints. Those are examples of false imprisonment. Of course, restraint without the doctor's authorization. It can have variations, okay? Because not necessarily physical restraints need to be that the patient is tied with ropes or restraints in the wrist and the ankles. Sometimes, for example, when a person is in the wheelchair, there is a device that can be fit in the wheelchair that is like a fitting board that can be connected to the wheelchair to have the facilitate the patient eating in the wheelchair while in the wheelchair. Okay, but if you lift this board uh, uh, attached to the wheelchair, the patient cannot get up and leave the wheelchair. And if you, for example, use this device and leave the device, is also considered a restraint. Sometimes CNAs, without the doctor's order, tie a blanket in the wheelchair client, okay, in a way that the client is covering the legs with the blanket but cannot stand up and lift the wheelchair, is also considered a false imprisonment. False imprisonment is a very serious, very, very serious crime. Uh, there are several cases, okay, of people that has been taken to jail. This is criminal law because had been having, generally it's a female, okay, person, uh, 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 prisoner in their houses. Is called false imprisonment, and this is a reason for going to jail. It's a felony. It's a serious crime. You can be involved in this kind of legal issue, okay, doing this kind of false imprisonment. And defamation is when you say or write something that affect the reputation of a person. We were mentioning that defamation can be used if you don't demonstrate. Okay, you write that the parents are being abusive and you don't demonstrate that. That's why you leave this responsibility of finding the proof to experts that are trained to find the proof and defend in case of demand for defamation. There are two varieties of defamation. The verbal is called slander, and the written is called libel. And I remember that I had this issue in my LPN anchors when they took my LPN anchors. And the questions can be appeared also in the RN anchors because it is required. What is required to an LPN is also required to be known by the RN. So the question of the LPN test can also be present in the RN test. Okay, so pay attention. That is the difference when you say something from a client or from the client's family. You say when you are, turning in your shift. You say this client is verbally abusive and is very annoying to the upcoming nurse. Take care because is very demanding and very abusive. And somebody is witnessing that you are saying that affects the reputation of the client. It could be a case of slander. But if you are very upset and you write in the documentation, okay, This is a case of abuse. This is a client that is very abusive. The family is very, rude, etc. This written information could be used, okay, as a proof of libel, which is a variety of defamation. So when it is spoken as speech, yes, is slander. When it is written with letters, okay, letter written, yes, is libel. Okay, so use this trick to differentiate both different, okay, type of defamation or tort. Again, select the legal term that is accurately paired with its description. Assault, touching a person without their consent. This is not assault. Touching is battery. Battery, threatening to touch. No, this is not battery. It is assault. So they are cross. So it is not. No, no. Slander, speech as, no? False oral speech, words. False oral defamatory statement. It sounds okay. Slander, saying slander. False written. No, this is libel. So we are sure that the answer is C. Those are ways that can be tested this. The nurse puts a restraint jacket on a client without the client's permission and without the physician's order. The nurse may be guilty of assault, battery, invasion of privacy, or neglect. Okay, of these four options given, which apply?
B.
Of
B.
course, battery. Yeah, because you are touching without permission the client. But at the same time, this is false imprisonment, but it's not mentioned here. So remember, you need to dance with the music that is played. If in the options, if you're thinking, this is false imprisonment, but in the options, there is no false imprisonment, you need to find which other option could apply. In this client, perfectly applies battery. So when you tie a person with a restraint, you are doing two torts, false imprisonment and battery at the same time. You have loosely applied a bed sheet around your client's waist to prevent a fall from the chair. And this has not been ordered. What have you done? You ensured the client's safety, okay? Because it's a priority. You committed an assault. You violated the client's right to dignity, or you committed a crime, false imprisonment. So the answer is this, because you are, restraining the freedom, the free mobility of the client. This is an example of false imprisonment. And it's a crime. It's a crime. The nurse cares for a client on hemodialysis from chronic renal failure. After several months of hemodialysis, the client declines to continue with the dialysis. Has a client with end-stage renal failure in hemodialysis that keeps the clients alive, has this client to refuse more hemodialysis and to refuse a kidney transplant? Yes or not?
Yes.
Of course that
Yes.
yes. Of course that yes. Okay, and it's autonomy. Autonomy. Are we good? Are we good? Okay. But now that we clarified that, it is most important for the nurse to take which action? Four options. Ask the client's family to encourage the client to change his mind. Ask another client, also in dialysis, to talk to the client and influence him to change his mind. Record in the chart, in the record of the client, this client's decision. Document the client's decision, accepting his autonomy. Inform the client about the eventual result of refusal of care. So you have asking the family to convince the client or change their mind, asking another person, no family, but in the same situation to change that. It is the same. And when two options are the same, they are incorrect. So you have two stuff to do that are correct. Document the client chart, the decision. You need to document that. And inform the client about the eventual result of not having the dialysis. Also, you are responsible of that. But they are asking of the two options, what is the most important? To document the client decision or to make the client aware of the consequence of the refusal?
Z. Where?
Of course,
D.
the last
D.
one. Because this autonomy is exerted after information is given. It's an informed decision. And it's important that the patient is aware of what happens when the dialysis is stopped. The patient is going to die. The patient is going to go to first uremia, okay, and azotemia. The BUN is going to be very high, and there is going to be a lot of symptoms that are going to last some days. Then a hyperkalemia, and then acidosis, and then the patient is going to die as a consequence of all those disbalances. So the patient needs to be aware of what is going to happen. The patient is going to enter in hospice to make the patient comfortable and to avoid feeling all the discomfort of those symptoms. Enough doses of morphine are going to be given to make the patient unsensible, don't feeling, okay, those discomforts. This is what is going to happen. So we already discussed that the informed consent is a document based in the autonomy ethical principle and is part of the Self-Determination Act, a law that protects the decision, the autonomy of the clients, and to be able to exert this autonomy and to give consent, you need to have three criteria: adulthood and mental competence, being informed, and voluntarily you need to give your consent. The information should be given by the provider because you don't have the knowledge to give the details of the procedure. And the client will give the consent to the provider, but verbally is going to say, okay, I agree with the surgery. No? I agree with the endoscopy. I agree with the colonoscopy, yes? But the nurse is responsible for giving the document to be signed and assess that the client has been informed, and then is co-signing, is signing together with the client, is the only document that the registered nurse signs together at the same time with the client. Because your signature, the RN signature says, I ask the client if he or she was informed, and he was well informed. I asked the client that he or she wanted to have the procedure. If the client is giving voluntarily consent and the patient wanted the procedure, and I'm signing to prove that the client is informed and given voluntarily consent. This is the meaning of your signature. Yeah? Who is incompetent to give consent? Okay, a person that is not in his mental capacity. So somebody that is under sedation, somebody that is under the influence of substances like alcohol or drugs that affect the mind. For example, a client with advanced, severe terminal dementia. What means that? Is the physician the one that need to determine if the dementia allows to give consent or not? Because dementia can be mild, can be moderate, and can be severe. A patient with mild to moderate dementia still can give consent, but a patient with advanced dementia cannot give consent. Same happens with mental retardation in children and adolescents and young adults. This is something that needs to be defined by the physician. And for example, people that have psychosis, let's see, schizophrenia, bipolars, etc. If they are compensated with a treatment, they can just give consent, okay? If they have an uncompensated psychosis, how do you know that the psychosis is uncompensated? The patient is having delusions, is having deliriums, is having hallucinations. In this state, in this situation, the patient is not able to give consent, is not mentally capacitated. But once they compensate and they compensate with the treatment, they can now give consent, okay? They can now give consent, okay? In those patients that are unable to give consent, okay, for mental reasons, somebody could be designated to give consent for them. You can do that in advance when you are in your mental capacity with something called durable power of attorney, in which you designate, without the need of an attorney, just the name, you designate a person to take decision for you if, notice the if you become mentally incompetent. So meanwhile, you are mentally competent, this person that you designated is not taking any decision. You are taking the decision. But if you becomes incompetent in a moment, then this person is activated and this person start taking decision for you. Also, you can write, okay, what you want and what you don't want. It is complementing, okay, the designation of the person, okay, of the proxy. Minors cannot give consent. So 17 and down don't give consent. But this has exceptions, and those exceptions are frequently tested. There are many, but don't complicate. You need to be simplifying for your English, not complicating. So a minor cannot give consent, except if this minor, so has 17, has 16, has 15, is emancipated. And you need to know that the 99.99 reason to be emancipated as a minor is the marriage. So if a minor marries, automatically is emancipated. If a minor is married, is automatically emancipated, okay? The court can emancipate, the court can do whatever they want. Being in the military, because you can be accepted in the army at 17, also emancipates. Don't insist that pregnancy emancipates, because it's not true. Recently, here, I think was a 10 or 11 years old girl become pregnant, okay? The pregnancy in this girl is not going to give the knowledge and the capacity to be emancipated. Don't be it. The judges and the law are not idiots, are smart people. They don't automatically emancipate pregnant girls. Okay, the girls need to demonstrate that deserve the emancipation to be emancipated. But pregnancy give certain rights to the mother. But this is lawyers' problems, not nurses' problems. And the hospital and the facilities have lawyers. So don't expect those very complex questions that you have been exposed before in your classes or in the practical practicing question test programs like ATI, etc. It is going to be very simple. A woman, 16, is married. Who is giving the consent? The husband, the father, or the own woman, yeah, because this woman, 16, once is married, is emancipated, period. Okay, period. This is going to be, I promise, the case of emancipation. Okay, non-emancipated are not emancipated, okay, are dependent, are not emancipated minors, can give consent in certain specific situations. And the most commonly tested is sexually transmitted disease or infections. So if you have a boy, 15, is emancipated? No, but got a gonorrhea. Can this boy go to the doctors and to the nurse and request medical attention, testing, and treatment, and demand that the parents not being informed to keep this gonorrhea confidential? The answer is yes. You are offended, you don't like that because you have adolescent children. Okay, this is not the problem. The problem is that the law says that for sexually transmitted disease, minors can give consent and can demand confidentiality. What is the most common situation a nurse is going to be facing related with minors? STDs, because minors are nowadays very sexually active with not too much knowledge. So is there an increased risk of catching an STDs if a minor is, so active in their sexuality? Yes. So that's why the most common question that you could have in your Nclex of minors no emancipated giving consent is a sexually transmitted disease. So be aware of that. And yes, you don't need to inform the parents. Okay? If this same minor has a fracture, you cannot do surgery without calling the parents of the minor and requesting the consent of the parents to do the surgery. Or if the minor has a pneumonia and needs an X-ray and treatment, you need to call the parents to request the consent for those procedures. So be able to differentiate the two situations. The other situations in which minors also can give consent and can demand confidentiality is the treatment of drug addiction, substance abuse. The prenatal care. What is prenatal care? A girl becomes pregnant, is a minor, and she wants to have the baby. And she wants to be cured the pregnancy to have a normal baby. She wants the prenatal vitamins. She wants all the care given for that. And she doesn't have either the permission or the parents are not in knowledge that she is pregnant. This is the scenario. Can this girl, 15, 16, go to a doctor, to a nurse, and demand prenatal care without being informing the parents and without the parents' consent? The answer is yes. No. The answer is yes. The law is protecting this fetus. Yeah, this fetus. The law is protecting this fetus. The law wants that this fetus have vitamins. The law wants that this fetus have regular evaluation. So this way, the girl who is afraid of the parents being informed doesn't want the parents to be informed. She's afraid that the parents can force her to have an abortion, whatever. Yes, the girls can demand being taking care, prenatal care of this pregnancy without informing the parent. Is the law to protect this pregnancy. Can this girl request an abortion without the consent of the parents? The answer is no. But I'm talking about abortion or prenatal care. I'm talking about prenatal care. Prenatal care. A girl, I'm going to repeat until you accept that. A girl that is pregnant can request care of her good pregnancy, continuing the pregnancy, even is a minor, okay, without the parents' consent. If the parents wants the girl to have an abortion and the girl doesn't want to have the abortion, the girls, okay, wins. The girls predominates, ¿de acuerdo? Because the law protects more than promote the abortion. It protects the pregnancy than to promote the abortion. Can a girl minor do an abortion without parent consent? No. And even now is even in Florida is more strict. Okay. And in other states it's even more strict. The answer is no. Abortion, no. Prenatal care, yes. Carrying on, continuing the pregnancy, yes. It's protected by the state, it's protected by the law. Okay, this is the law, so have that in mind. And contraceptive. Can a girl, 15, go to a doctor and request a prescription of contraceptive pills without telling the parents? The answer is yes. The answer is yes. A girl can request contraception without consent of the parents and without information of the parents. So have that in mind because it is frequently tested. But the one that is generally tested is the most common situation. Somebody, a girl or a boy with a gonorrhea, with a chlamydia, with unsexually transmitted disease. No need of informing the parents. No need of parents' consent. Period. Accept that and you are going to be aligned with the law independently of your opinion or whatever. Okay? Don't forget that in case of emergencies, if the client cannot give consent, suppose the client is unconscious and needs an emergency intervention, and obviously the patient cannot give consent, and there is nobody, no proxy that can be consent, then the law protects the decision of the hospital and the doctors of continuing with the care without the need of consent, because we assume that if the client would be conscious, will give the consent. Okay. And yes, we say that can be given by the proxy. The clients cannot give the consent. And don't forget that if the client gives a consent, can discontinue, can rescind, can cancel this consent at any moment. At any moment. Those are the most important aspects of the consent. Client going to a hysterectomy is offered a consent form by the nurse to sign the consent. The client states, sure, I'm eager to have this hysterectomy, this surgery, and being able to have more children. You need to know that hysterectomy means the extraction of the uterus. And once the uterus is extracted, this woman won't be able to have more children. So obviously, this woman wants a surgery, wants to give consent for a surgery that she doesn't understand. She didn't understand the information. So what should the nurse do next? What should the nurse answer? A, you will not be able to have more children after the surgery. B, do you already have any children alive? C, please don't sign the form and let me communicate with your doctor. And D, did the doctor explain you what type of surgery is a hysterectomy? Okay, so let's analyze this question. Okay, so let's rule out a stupid option. Do you already have any children alive? This answer could be yes or not, but it's not going to make a difference. Independent that they have or not alive children, the situation continue being the same. Okay, let's go to the last one. Did the doctor explain you what type of surgery is a hysterectomy. If the patient says yes, do you allow to sign the consent? You're not understanding me. The question say, tell the woman, did the doctor explain you what type of surgery is a hysterectomy? Okay, you ask that to the woman, and she say yes. He explained that to me. You are going to allow the woman to sign the consent because the doctor informed what is hysterectomy?
No, because she does
No,
not
because
understand.
exactly she demonstrated that don't understand. And if she says no, the same, you don't allow the woman to sign it. So you rule out that because it doesn't make any difference. Okay, say yes or not is not a difference. So you are left with two options. You will not, you inform the woman, you will not be able to have more children after surgery. But the doctor didn't tell me that. Didn't tell me that. The doctor didn't. No, I think that you are wrong. Okay, let's see. Please don't sign the form and let me communicate with your doctor to tell this. What is better, A or C?
Sí.
You know, I don't understand very well, but I think that you said C, and I don't know if you want to say something. I don't care if you want to say something because you already passed my Nclex. Okay, the answer is C. Because if you assume the responsibility of informing the woman that with a hysterectomy, okay, no more children can be taken, still it is a situation in which the woman has no the proper information for the part of the provider. So it is an irregularity. And who opinion is more expert is going to predominate from the point of view of the client, your opinion as a registered nurse or the opinion of the surgeon that is going to do the surgery. So maybe an argument, a discussion, a doubt, a conflict is going to raise if you say the woman, you cannot have babies, okay? Didn't the doctor tell you that you cannot have babies with that? So it is going to be a conflictive, conflict generating option. But then simply say, okay, don't sign the consent. I'm going to talk to the doctor. Doctor, the woman told me that you're going to have hysterectomy, that she wants to have more baby. I think that you need to talk with this woman. You are the authorized person that is going to give this information to this woman. Is what is demanded. You need to give that. So C is the best option of this question. Next, a client is going to have a mastectomy and is brought to the on-call area where it's received by the circulating nurse. Understand that a patient that go to surgery are in the med-surg floor in a room, hospitalized in a room, and you are generally the nurse working there. This woman, when is going to have the surgery, is going to be moved to a stretcher, and the woman is moved to the surgical area, which is distant from the med-surg area, and you transport the client with the stretcher there. And then you give the client to another nurse. You transfer the client to another nurse that is there in the surgical area, which is the circulating nurse. When the circulating nurse receives the client, receive all the paperwork, all the stuff, and receive the client and all the information that you gave, probably you left, and then he, circulating nurse, discovered that the staff nurse of Mr. forgot to make this client that was brought for surgery and is going to have surgery in the next 15 minutes. It's in the on-call area because it's going to be passed once the OR is ready. It's going to be passed to the OR in 15 minutes to have a mastectomy, okay, the removal of a breast because breast cancer. So the circulating nurse discovered that this woman has not signed the consent. Probably she is totally informed and aware that she has breast cancer, that she needs the mastectomy, later radiation and chemotherapy. She knows all this stuff. We assume that, okay? Probably probably she already gave the consent to the doctor when the doctor tells, I need to remove your breast. And even you need to give me a consent to remove the lymph node, etc. But then there is need of signing a consent. So this is the scenario. And now the question says, what should the circulating nurse do first? The word first demands what you do chronologically prior, o sea, a chronological prioritization. And you have informed the anesthesiologist, inform the surgeon, find a proxy, or determine which kind of medication has received the patient, okay, that is going to have the mastectomy. What do you think should be done first?
Determine what type of medication has been already given.
C.
C.
So everybody agree that the first that you need to do is to determine if the woman is mentally competent or not. And how you know if this woman is mentally competent or not, you need to determine if we already received any medication that can alter the mind of the client, or if has not received any medication. If she has not received any medication, she is alert, she is aware, and she can sign in this moment the consent, okay? And the circulating nurse is going to co-sign the consent. He's going to ask, you were informed, you know who is going to do the surgery, you know why the surgery. So she is informed, you allow the patient to sign, and you co-sign. If the woman has already received medication that affects her orientation and her capacity of decision, she cannot sign the consent. But the first that you need to do is to determine if she has received or not this kind of medication. If she received already medication and is not able to sign consent, then you need, the next step is to find a proxy that could sign for her, that had been previously authorized by her to take decision for her when she is mentally incompetent. If there is no proxy there is nobody that can be, then you need to inform the surgeon. But it is the last that you need to do. Okay, so those are examples of Nclex style question, because this question is very similar to one that has been in the Nclex. So remember that the advance directive is something that is done in advance when the person is mentally competent. So people that are okay, are good, are okay, are the people that write the living will and the durable power of attorney. So people that are careful, when they are okay, they have good head, good mind, they do this. It is very simple, okay? It is even is not expensive. It's something that is the only need is the intention. The Joint Commission that regulates the accreditation of the hospitals and facilities demand, okay, to the facilities that when a patient is admitted, always the nurse need to ask the client if the client has already advanced directive, either living will and or durable power of attorney. And if the patient has not any of these advanced directive, promote, offer to do, to create, to initiate this advanced directive. So they offer the resources, the facility of doing that. It is a requirement of that. If the patient has an advanced directive, you need to request a copy of the advanced directive and put that in the chart of the clients in the medical records. Okay, and always is good to demand the client to designate a person that is going to function as a durable power of attorney and is a person authorized to receive any kind of information related to the client if necessary. Okay, the difference between living will and durable power of attorney is that living will is a list. is a list, no, a list, a written list, where you say what you want. I want this, I want this, I want this, I want this, and what you don't want. I don't want this, I don't want this, I don't want this, and I don't want this. But this list, this living will for healthcare, is written, is signed by you, and signed by two other persons that are witnesses. By the way, those witnesses, okay, one can be a relative. The other should not be a relative, but cannot be the nurse or the physician, the treating physician. Can be a nurse that is not related with the case, but cannot be the nurse related with the case, and cannot be the physician related with the case. So this is, okay, a living will, okay? And in the living will, you can have a second page where you say, this person is going to take decisions, medical decisions for me if I become mentally incompetent. So both the living will and the proxy are inactive when you write them. And meanwhile, you are in your mental capacities, those advanced directives continue inactive. When they activate, okay, in the moment that you become mentally incompetent. Do they expire, has expiration date? The answer is no. Meanwhile, you don't revoke, meanwhile, you don't change. These documents are latent, okay, active. And they are activating when you become mentally incompetent, terminal, etc. Okay? Muy bien. Entonces, this is the big difference, okay, of both. One of the stuff that you can request in this advanced directive is to be do not resuscitate. You need to have very clear what means do not resuscitate. It means that if you die, okay, if you die, and dying means to become unresponsive and without pulse. This is the rapid criteria that we use to determine that a person is dead, a person that is unresponsive and has no carotid pulse. Is it an adult, no? Okay, in that case, the patient could be resuscitated with basic life support and advanced cardio life support. If the patient refuses the basic life support and advanced cardio life support, if the patient dies, then it's considered DNR or do not resuscitate. But what is important is only refers to basic life support and advanced cardio life support. Basic life support include 1, chest compression, 2, artificial ventilation, and 3, defibrillation, okay, electrical shock. Advanced cardio life support includes a part of this, the administration of medication, etc., okay, pacemakers, etc. Very good, okay. Entonces, this is requested by the client, but these need to be ordered, prescribed by the doctor. So you can ask to be DNR, but the doctor needs to written order the prescription. So when somebody says, I want to be DNR, first make an assessment. What is DNR for you? Because maybe the person doesn't know exactly what is DNR and doesn't know the eventual consequences of being DNR. Then if the client knows what is DNR, the majority knows that, then the next step is to call the doctor as soon as possible so the doctor writes, orders the DNR status. Yeah. Remember that if you give chest compression to a patient that you know is DNR, is considered battery. Okay, there are different types of the DNR. This is not going for the Nclex. Nclex, this is different. The DNR in hospice different from the DNR of the admission of a hospital, and it's different from other DNRs. It is not important. The important is that you understand that independently of the type of DNR, need to be written by the doctor, and the DNR refers only to cardiopulmonary resuscitation. For example, a person that is DNR has an infarction, myocardial infarction. Yeah, the patient is DNR, but has a myocardial infarction. Can this person has open heart surgery? Yes or not? I think that everybody left and left me alone.
No,
No,
Professor,
no,
can you repeat
no.
the question, please?
Okay, a patient who is DNR, do not resuscitate, has a myocardial infarction and requires open heart surgery. Can this patient be done open heart surgery? Yes or not?
No.
Yes.
Okay, the answer is yes, because the DNR only apply if the patient is dead. A patient with myocardial infarction that could improve with cardiac bypass, with the coronary artery bypass, is dead. A patient with myocardial are dead. No, no are
No.
dead. No are dead. So say the DNR doesn't apply to a patient with myocardial infarction. And this is the most important misconception that nursing students and nurses have, that a patient that is DNR, nothing surgery extreme should be used. Okay, they confuse DNR with hospice. It's not the same. Hospice is a person that is terminal, has no possibility of improvement, is declared DNR, and then is given no curative treatment, only comfort treatment. It is another stuff, it's different. It has not to do with this. In this case, a person is DNR because the person doesn't want to be resuscitated if the patient dies, but the patient has a health problem, needs open heart surgery. No, there is no contraindication. Being DNR, you can go to open heart surgery to solve a problem in the heart. Why? Because you are not dead. And DNR means no, don't resuscitate me. So what condition is necessary to activate DNR? Don't resuscitate me. You need to be dead. Is a patient with myocardial infarction dead? No, it's not dead. So have this concept clear, because it's important that you are denying attention to people that are DNR when you cannot do that, because a person that is DNR can have medical attention. Okay, what cannot be done is resuscitation. CPR. Okay, have that clear. So this person with myocardial infarction that is going to a open heart surgery dies during the surgery, cannot be resuscitated. No, so it's important, this concept. Okay, guys, this is what I have for you today, of review of content that the school has determined that our graduates have a lot of a need of refreshment of this area, because the question that, Nclex report us how you are doing in this different type of question, and there are going to be a lot of problems in the legal, ethical, and this kind of issue in Nclex. So it looks like people don't like it, and for that reason are failing this kind of question. Okay, any question, any doubt? Are you okay?
No, thank you, Professor.
Okay,
Good
so
Thank you, Professor.
thank you for your attention. Has been a pleasure, and
Thank you so much, Professor.
see you soon. Okay, see you soon. Bye-bye.